Okay, so right now we'll have Dr. Aaron Vinik come up and speak with us about PNETs. Dr. Vinik?
Have I got control of this? Is there? Oh, that's PNETs. Yeah. Well, up and down. That'll work fine. That's a very, very difficult act to follow. And I know that Phil did actually end up playing for a lot of the sympathy about what happened. But after Katrina came Irene. And my place is in the Outer Banks of North Carolina. And I got a very nice message from both Phil and Jean to say, get the hell out of there. You don't know what's going to happen to you. So I got the hell out of there, and my house took the beating. So I empathize with you and understand perfectly well. I was very happy that I got the good advice, because otherwise I might not have been here with you people today. So let me talk to you about pancreatic neuroendocrine tumors. I have a lot to cover. The handout for you is very extensive. I've shortened it very considerably, and I tend to talk fast. So, but what I want to tell you is why I felt it was safe for me to talk to you about this complicated matter is with the internet, my patients come self-diagnosed, have second opinions, and already belong to a support group. So you all have all this information already over here. I just happen to be there to try and guide you along this bit of information about PNETs. I noticed when Phil asked earlier that there are not too many people who put up their hands about PNETs. The reason for that is PNETs are the neglected side of NETs. You see this wonderful little picture over here. This little picture of this little girl is her boyfriend is kissing her girlfriend, which is an iNet or a CNET. She's the PNET, and she's being deprived of the recognition she deserves for having this condition, PNETs. So let's get into the question of what PNETs are. If you look at the distribution of all the pancreatic neuroendocrine tumors we see, about 56% of those are carcinoid, which leaves you with the remainder of the tumors being PNETs, pancreatic neuroendocrine tumors. And they comprise the insulinomas, PPOmas, gastronomas, vipomas, gluconomas, and somatostatinomas. For me, the most important thing that ever happens in my life is somebody is diagnosed with pancreatic adenocarcinoma, and they send them to me to say, is there anything we can do? So I said, yes. If that person has pancreatic adenocarcinoma, they're going to be dead within 6 months. If they got a neuroendocrine tumor, which is a PNET, I can keep them alive almost forever. So I just have to do one thing. I have to be able to recognize the PNET and make that diagnosis, because then we have something to offer. PNETs behave in the following way. They are either functioning, and the morbidity and mortality results from the hormone production and the hormone-related syndromes. Secondarily, tumor expansion. And I'll show you that too. On the other hand, it could be non-functioning, and the non-functioning, the morbidity and the mortality results from tumor expansion. So when you hear about like CNETs or iNETs, in PNETs you've got to think, one, is the tumor expanding? Two, is it making a hormone that's going to kill you? Okay? And three, is there a classic biochemistry? All three that you have to think about when you're monitoring these. Where does this come from? You heard earlier today talking about the type of cell, and Jean spoke to you about Kolchitsky cells, but the neuroendocrine cell is a really interesting cell. It's a totipotent cell. It can make anything, anything. And at one time it'll make one thing, another time it'll make something else. So here it is. It can make amines, it can make peptides, and in the process it stacks up all the precursors that it needs and to package the material so that it can secrete hormones. At the same time, when it packages this material, it has a little chaperone that goes with it. And you've heard it today. It's chromogranin A. And every time it releases a molecule, either an amine or a peptide, it releases that chromogranin. Isn't that nice? The deity in his or her wisdom gave us the chaperone that we can use to measure so we know whether or not you've got an active secretory cell. So now let us look at the cell in a little more detail. Here's the cell, and we want to get it out of the way so that we can look at what it can do. And here you see this proto-differentiated cell can be the enterochromaffin cell. If it differentiates into an alpha cell, it will make a glucagonoma, a beta cell an insulinoma, a delta cell a somatostatinoma, a G cell a gastronoma, a PP cell a PPoma. Lo and behold, it can also differentiate into other cells, like the EC cell, so you get carcinoid of the pancreas. And today you heard from Tom Odorizio about a paper that's going to appear in the Archives of Surgery by Howe and colleagues that pancreatic neuroendocrine tumors make serotonin. Isn't that a nice surprise? And I'll come back and tell you why that is important. Gastronoma, ACTH, Cushing syndrome, growth hormone-releasing hormone, acromegaly. These are, see Daisy. Those are all very interesting hormones that can be produced by the pancreas and produce very interesting clinical syndromes. So today, as an endocrinologist, if I see an acromegalic and there's no tumor in the pituitary, I look in the pancreas. If I see Cushing's and there's no tumor in the adrenal or the pituitary, I look in the pancreas. That's where we will find these unusual tumors. Then there's the VIP secreting tumor, which produces watery diarrhea, and the humoral hypercalcemic factor of malignancy. And probably the latest two on the horizon, if it makes insulin-like growth factor 2, you can become hypoglycemic. And INGAP, Nesidioblastosis, that's the gene we cloned and sequenced back in 1997. It's responsible for regenerating pancreatic islets from stem cells, duct cells in the pancreas, and it's now got to the level where it's been used in clinical trials for the treatment of diabetes, the other side of what I do. So there is something good that can derive from that. These tumors can be situated in different places, and the primary tumor can be right here in the foregut, and what the foregut includes is the pancreas. So you may not think of it like that. And from this pancreas, you can develop tumors which can metastasize to different places. Foregut also includes lung, and foregut also includes the ovary in a female, because the ovary drains into a plexus of veins where it behaves like something that's coming from the front of the gut. Then there are the midgut tumors and the hindgut tumors, and mostly we've started seeing these tumors metastasize locally to lymph nodes, and then they can go further afield to the liver, but they can also form distant metastases in the liver and in bone. And as you keep people alive longer and longer, and you're using some of the new therapies, we are now beginning to see more and more of the distant metastases. Okay, so now let us take this a step further. You've heard today about the pathology, so I don't have to go over that with you. We look at mitotic divisions, we look at chromogramin and A staining, and we look at Ki-67. This is a beautiful example of very low Ki-67 here, very high there. And does that change how we look at the tumor? Yes, it does. We look at a three-tier system for JEP-NETs. In pancreatic, there's a well-differentiated endocrine tumor, or you go on to a well-differentiated endocrine carcinoma, which is like a malignant carcinoid, and then a poorly differentiated tumor. And that determines the behavior of these tumors, going from well-differentiated through to poorly differentiated to de-differentiated and metastatic. Now, Joy Ardul, you heard her name brought up earlier today, looks at chromogranin A and also types the tumors to see if they got somatostatin receptor subtype 2, and you heard Tom Odorizio talk about that in terms of predicting the responsiveness. There are other biomarkers, but notice the list of hormones that people are beginning to measure, because there's some weird and wonderful syndromes. There are syndromes called paraneoplastic syndromes, people who present just with fever, people who present just with generalized body aches and pains, people who present with muscle weakness, and people who present with nerve damage. All these things coming from these neuroendocrine tumors, and we're beginning to learn more and more about these different clinical syndromes. It's bad to have a high mitotic index, that's cell division, aggressive cell division, over 20 mitotic index, and a Ki-67 index, cells that are dividing aggressively over 20. Look to the right of this line by Pape and colleagues, and look at how, if you are a G1 stage with a low mitotic index over here, your chances, your cumulative survival over here, it can be many, 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 many years. without metastases. But if you have a high mitotic index and a high Ki67 index, your survival time is reduced very dramatically. That's what we want to know about those. And that's put out graphically. Now, these are tables that are in the handout. They're also in the book that's on the table. We don't see people always who come to us and say, I have a pancreatic neuroendocrine tumor. They may come to say, I have flushing, diarrhea with steatorrhea, which is fatty diarrhea, wheezing, I have a peptic ulcer, and these are some of the hormones. But the sites are generally elsewhere. But when we take this a little further and we look at the oh, God, you're still here with me. This is a diarrhea syndrome, and we say, well, where can that come from? If we look at hypoglycemia, dermatitis, dementia, diabetes, deep vein thrombosis, notice pancreas, 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 pancreas. Okay? So these syndromes all come from the pancreas. They're very diverse, from hypoglycemia through a skin rash, which I'll show you, dementia, diabetes. 1/3 of the patients we see have diabetes coexisting with a neuroendocrine tumor. 37% is the number. Some people say, but you have the highest index in the world. Lowell Antin and I just published a paper, and we showed in the general population it's about 10%, but people refer all their cases to me when they have difficulty with the diagnosis and its management. So I get to see those people. Or they can come to you with a skin rash like this. And this starts off as a little red spot, and then it ulcerates, and then you desquamates, and then it becomes brown, and it's usually in the groin, and it can be the whole body. This is migratory necrolytic erythema. This was described by a British hematologist. His name was Sweet, and they called the syndrome the Sweet syndrome. Is there anything sweet about this? You know what is sweet about it? If you take out that tumor, it goes away, and it disappears completely. So once you recognize it's a glucagonoma. So what is about the diarrhea? We ask a question of all our patients, just very simple questions. What happens to your diarrhea on Ramadan? Diarrhea that persists despite fasting is an endocrine tumor. Or if they don't understand what Ramadan is, we say, what happens on Yom Kippur, the Jewish day of fasting? And if it persists on that day, then we know it's a neuroendocrine tumor. If they look at us blankly, we take away their food and put up an IV and see if the diarrhea persists. And then we know that it's a neuroendocrine tumor. Otherwise, one of the problems we face is this, is that Dr. Waltering likes to use the term wannabes. Now, my worst story was a 7-year-old beautiful redhead boy with blue eyes, and who had a beautiful redhead mother with blue eyes as well. And he had persistent diarrhea. And he'd already been around the world. He'd already seen Tom Odorizio, who was already left, and said, we can't make the diagnosis. And so I saw this beautiful mother and beautiful child and tested the stool to see whether or not we could account for all the osmoles, all the electrolytes by what was in the stool, and there was a missing something in the electrolytes in the stool. So we tested for that, and it was phenolphthalein. The mother was poisoning the child by giving it laxatives. So it appeared to us with a persistent diarrhea syndrome. When we confronted her, she said, well, her husband was walking out on her and had an affair. I couldn't believe that anybody would look at this woman and not want to have her for life, but that's exactly what happened. So this is part of the detective work. When you think about the causes of these diarrheas, they're watery diarrhea, hypokalemic hypochlorhydric acidosis, WDHHA syndrome, or the bipoma. I'll show you an example. Gastronoma syndrome, carcinoid. Medullary carcinoma of the thyroid. Now, I heard you people ask earlier today, the question is, can we use these new drugs like Sutent or sunitinib or the other drugs, the mTOR inhibitors? Can we use them for other conditions? There are two other neuroendocrine tumors that we see. One is medullary carcinoma of the thyroid, and the second is a pheochromocytoma. We've actually published to show you can use in both situations. They happen to work very well. Medullary carcinoma of the thyroid produces diarrhea, and the thing you need to do always is just feel the neck, because that's where the tumor is. Surreptitious laxative abuse, that's something you have to consider in unusual cases. So here's how it works. If you're making too much gastrin, it drives the stomach to make acid. The acid breaks. I don't know why this is doing this, but I apologize to you. Which way do I want to go? No, I don't want to go there yet. There. All right. So this drives the stomach. The acid inactivates all the digestive enzymes, and you get diarrhea. You only have to ask one question of these people. Have you ever taken a purple pill? If you take a purple pill and the diarrhea goes away, you've got a gastrinoma. It's as simple as that. You don't even have to measure the gastrin. On the other hand, is if the diarrhea persists despite not eating, then you have a secretory diarrhea, and it's one of these over here. So you ask two questions, and you know you've got a neuroendocrine tumor. And then you go on from there. That I've just shown you. So now we go on and say, what about the silent liver metastases, growth hormone, acromegaly, Cushing's, pigmentation, anorexia, nausea, vomiting, abdominal pain? Guess where it's all coming from? The pancreas. Okay? So the pancreas harbors a lot of them. Almost half the neuroendocrine tumors we see come from the pancreas. Okay. Now let us then say, what else can they do, these tumors? They metastasize to bone. As we follow people for long periods of time, we actually begin to see osteoblastic and osteolytic. Either they form these dense metastases like this in the spine, or the ones which make holes in your head that look like that. The good thing about it is we have markers for those now, and we can measure in your bloodstream markers which tell us that you've got metastases to bone. And then we can go about treating you, and we can actually stop the pain, and we can have people running around very well. This person over here ended up, he was a fireman who wanted to go skiing, and he said, was it safe for him to ski? And when you look at all those holes, you worry about it. So we gave him intravenous bisphosphonate, he went off skiing, and he was fine. This can result in pain, fractures, spinal cord compression, and tumor incurable when that happens. But you can make mistakes too. You've been hearing about the different techniques that we have. This young man was referred to me, and he was told that he had multiple metastases. You see these black spots? You've been seeing lots of black spots today, haven't you? And the black spots in the shoulder, the black spots in the ribs, the black spots in his wrists, the black spots in his pelvis. But he also had black spots in his knees, and he had black spots in his feet. The nice thing about these tumors, if you know one little fact, is they never metastasize below the elbow, and they never metastasize below the knee. So then you go and have a look, and you do all the biochemistries, and they're normal. And now what you do, shown on the side over here, is an Octreoscan, and it's clean. Absolutely clean. Isn't that wonderful? This chap's a Thai boxer. And he has multiple trauma to his shoulders, his back, his wrists, his feet. And now all that is inflammatory change. It's an arthritis that he has. He has one thing in addition to that. He has psoriasis. So he has psoriatic arthropathy and Thai boxing, and it was mimicking a neuroendocrine tumor. I'm sharing with you the detectiving that goes on with the complexity of some of the patients that we encounter. Then we will localize, and there are multiple localization procedures, such as ultrasound, CAT scans, MRI, PETs, Octreoscans, MIBG, angiography, and beta sampling. This is a patient who has a small tumor, a gastrinoma, that is found by endoscopic ultrasound, and you see the tumor there, which is a gastrinoma. This is a patient on CT that you find all these hepatic metastases, so CT becomes useful to us as well. Sometimes you can't find these little tumors if they're insulinomas, and we do angiography, and you can find them. You heard today, too, from Tom Odorizio about GLP-1. It's the new form of diagnosing an insulinoma. It's going to replace Octreoscans because it binds, the GLP-1 binds to the pancreatic insulinoma. This is just to show you how wrong you can be. This patient was said to have no evidence of metastases on a CAT scan. You see this nice clean liver with a big stomach bubble over there, but on a Octreoscan, this liver is loaded with metastases. So don't be satisfied with one modality, and that is why we never settle for one modality of trying to identify what these tumors are. This is a patient who had a pancreatic polypeptide tumor, and he had multiple metastases, which were highly angiogenic. They had a big blood vessel involvement as well and proliferation. And it's one of the hallmarks of one of the tumors from the pancreas called a PPoma, and you can find them angiographically very nicely. So you've heard about CT and contrast enhanced CT scanning, and I don't have to show you that, but they can be very pretty pictures that you do. And you've heard today from Tomography about PET with 68 gallium Ga-DOTA Octreotide, and I'll just show you some of the other pictures that say, yes, that's where we'd like to go. What about making the diagnosis by immunohistochemistry? I've shown you that by immunohistochemistry for a pancreatic NET, you will do chromogranin A, the backup synaptophysin, Ki-67, but here you need the individual hormones because you've got to account for what's accounting for the syndrome. Now, you want to know why? Because I showed you what the cell can do. This cell one day can make insulin, and the next day can make gastrin. One metastasis will make one hormone, another metastasis will make another hormone. Gene Waltering has shown you that before, that each metastasis can make its own thing. And then the syndrome will change. It'll change from hypoglycemia to peptic ulcer disease as we go with time with this. And then we like to type the somatostatin receptors. This is just how pretty it looks with a synaptophysin stain. There's the chromogranin stain, and here's Ki-67 antigen, and that's what we like to do for pancreatic neuroendocrine tumors. So the clinical syndrome may be hypoglycemia, peptic ulcer, a rash, diarrhea. We like to exclude all the other causes. I showed you a drastic example of what happens with a factitious syndrome induced, which we have every now and then. I told you about medullary carcinoma of the thyroid we have to think about as well. But there are other conditions such as hypothyroidism, Cushing's disease, and factitious we have to think about. We then, because these tumors produce chemical substances, we like to measure not only the pancreastatin, which you heard about, chromogranin and urocinin A, but also the possible hormones they produce. People who have flushing syndromes, in our hands, often have histamine excess, and they are like mastocytosis, so we do histamine measurements. The NTX or N-telopeptide tells us whether you've got metastasis to bone, so we measure NTX in all our patients to see if they have metastases. And then if we have tissue, we're looking at chromogranin, Ki-67, synaptophysin, and the specific hormone they make. And then you can go on to symptomatic treatment. You localize and resect. And you heard Phil Boudreau said, I don't think a neuroendocrine tumor patient ever escapes the knife. And every one of them have had the knife in some way or other at different points in time. And we endorse that you need to look for the tumor. Even when they have liver involvement, if the liver involved is less than 50%, we ask them to resect. And then, or do radiofrequency ablation. If it's over 50%, we still consider partial resection because, as you heard from Boudreau, these livers can regenerate, and they do a very good job of regenerating. And if that fails us, then we start considering therapeutic trials. And if they have extrahepatic METs, you heard today from M2 that we still go for the primary. We still go for the primary and try and get the primary out because of the likelihood that you'll get a response of the secondary. And then if they're metastatic, we still do octreotide is our first stage of therapy, and we go on to further therapy after that. Now, I can skip this over here because, as Gene Waltering has told you, we like to measure the levels to tell us whether or not we're at the right level. Now, I just want to talk to you quickly about the use of somatostatin, tyrosine kinase, and mTOR inhibitors for pancreatic NETs, where we are with that. The thing that you heard a little bit about earlier today. So let us talk about why we think that there may be a role for these new drugs and these new combination therapies. So what you see here is the neuroendocrine tumor angiogenesis, that's blood vessel growth, that you need a road that leads into this over here. There's no way that you can actually get there unless you have a blood vessel. So you have endothelial cells, and they're dependent on the vasoendothelial-derived growth factor. There are cells which line these tumors, which are pericytes, and they're dependent on another growth factor, platelet-derived growth factor. And the tumor cells themselves may be dependent on IGF, insulin-like growth factor, or somatostatin, and they activate complex metabolic pathways which are dependent on cell survival, cell proliferation, cell migration, and new blood vessel formation or angiogenesis. Wouldn't it be nice if we could target each one of these? so that we could actually get at the whole complexity of what drives these cells. So somatostatin could be, sorry about that. Somatostatin here could be used to stop cell proliferation and growth. It may have some anti-angiogenic effects. And we can target the platelet-derived growth factor or the VEGF receptor, VEGF, VEGF, vasoendothelial-derived growth factor, with a drug like sunitinib or Sutent, a tyrosine kinase inhibitor, or target further down the path with an mTOR inhibitor, so we could inhibit tumor angiogenesis and cancer cell proliferation. That would be a nice place to be. So that I'm going to elaborate on for you just a little bit. Somatostatin analogs, people were talking about the first cases that were seen. My first case we published in 1978 of the use of somatostatin for a woman who had a malignant pancreatic neuroendocrine tumor metastatic to her liver. And she had a very large liver like this, and we gave her somatostatin. She got acute onset of pain in the right upper lobe of her liver, right over here, very severe, with high fever and chills and aches. And then when we looked at that again, the whole tumor had become like the black hole of Calcutta. It had disappeared completely. It had necrosed. She was a school principal in Chicago who came to see me at the University of Michigan. And 20 years later, she came to visit me again. And she said, I've done very well, haven't I? I said, yes, you've done superbly well. We're so proud of you. She says, well, the Lord gave me 70 years and 10, and I'm going to live my 70 years and 10. And I said, did you think we had anything to do with that? That was the introduction of somatostatin in this country. And she said, yeah, the Lord guided you in giving it to me. And so I'm pleased that that has happened as well. So I feel good about that there is a deity over there whose guiding hand sent us to do the right thing. So you have two varieties of it. Somatostatin itself has a very short half-life, about 1 to 3 minutes. So if I give it to you, I have to give you multiple injections, or I have to give it to you by intravenous infusion. Octreotide has a half-life for about 100 minutes, and it's just a small little portion of the peptide, this part. That's the active portion of the peptide that can do all the things that the whole molecule can do. There's another version of this called lanreotide, and I'll show you just a little about the comparison of the two, because that's where we are in clinical trials right now. You've heard before today about the binding to the different types of receptors, going for the receptor type 2, but there are 5 different receptors. That's 14, somatostatin 14. Its precursor, somatostatin 28, which will bind to all 5 receptors. There is, down here, octreotide, mostly binding to 2 and 3, and lanreotide binds to 2 and 3 as well. And then, of course, the new compound that you've heard about, the lanreotide and octreotide binding to 5 as well, and SOM230, the new or pasireotide, binding here to 1, 2, and 3, maybe a little bit at 4. So that is what we needed. We needed to target all the different receptors as well. So let us then see what this looks like. Here's octreotide LAR versus lanreotide depot. People said, how many of you are taking LAR? So you know all about how difficult this is, and the shots, and the amount of pain, and the discomfort, but you've lived with it for a long time. So lanreotide came along and said, here's the difference in the syringe. This one has this big, nice, long syringe over here, and it's all this volume that we have to give. With the lanreotide depot, we'll give you this nice, short needle over there. We'll just jab it right into your butt, and it's a nice, thin syringe with a very small volume. So that's what you'd expect. It should be a whole lot better. Who's taken lanreotide? No lanreotide. Well, that's what transpires. They've had a lot of difficulty recruiting patients into the study. We happen to be the lead center for recruiting for the study. And I can tell you how much difficulty we have. One shot of this, they say, I'm out of here. I'm going back to that other stuff. I mean, I shouldn't say that, but still, I'm trying to finish the study and tell you about it. So now you want to ask is, why are these drugs valuable to us, the somatostatin analogs? Now, you heard earlier today from Gene Waltering about the PROMET study, that they arrest the growth and the progression of the tumor. And I am an endocrinologist, and I want to know what secretions can I control with somatostatin. So I can control gastrin, I can control glucagon, insulin, pancreatic polypeptide, VIP. I can do very well. I can't control somatostatin with somatostatin. I tried, but it doesn't work. But the exocrine secretions of the pancreas, gastric acid, we can turn off gastric acid secretion. So a person has a gastronoma, we can control the acid so they don't die of a perforated peptic ulcer. And what about amylase, lipase, and trypsin? People with pancreatitis who have got an increase in, who have a diarrheic syndrome, we can control that as well with somatostatin. And people who have fistulae, we can control the fistulae, and we can actually control the rate of gastric emptying in people who have abnormal gastric emptying as well with somatostatin. There are a whole lot of uses. And some people who have a drop in their blood pressure, when they get a little dizzy when they stand, we control that as well because it has very powerful effects on blood flow. So these drugs are very useful to us for some reason, for a number of reasons. Jean Wolfing also told you about Joy Ardell and her measurement of neurokinin A and his own measurements of neurokinin A to say, well, look at what's happened. If you take neurokinin A levels above 50 versus below 50, so that if you have it above 50 over here, you're going to have a very short life expectancy. But you can do twice as well or 3 times as well if you have a level below 50. He also told you that if you restored the level towards normal, that you could actually get back to that. But Joy Ardell collected blood samples for many, many, many years. So she went and looked later on in life to say, hey, the natural history of these tumors has got better. So now people are living much longer with levels of neurokinin less than 50. What do you think happened? Good for you. What happened over there? Was that you, Gene? All right. This is the somatostatin era. It's changed the life expectancy of people. So although it was introduced to control symptoms, and I showed you all the secretions it can control, this over here told us that it does a whole lot more than that. A whole lot more than that. That it actually controls, improves your life expectancy. And one of the ways it's doing it, and you can see it, is with that marker. So somatostatin in PNETs are safe and effective. Long-term administration is safe and effective. In NETs, these analogs control symptoms and some tumor markers and are relatively ineffective in controlling tumor growth. Symptomatic escape may require short-term acting analogs as well, and you all have experienced that, where you break through the effects of the long-acting. Radioactive analogs, I had slides on this, but you've seen them already, so I pulled them all out. They're in the handout. Are promising but have yet to fulfill their promise, certainly in this country. New and better drugs are needed. So we were left with that, and we only had one drug. From 1978 till this last year, we only had that drug. You know that. That's the only drug we had. And this last year, we got 2 drugs approved. So we're in a nice place, right? So let us look at the drugs that got approved. The clinical trials were for tyrosine kinase inhibitors and mTOR inhibitors. So now remember the picture I showed you, that you wanted an anti-tumor effect of the drug. You also wanted to stop vasoactive endothelial growth factor, stimulating angiogenesis, and you wanted a drug that would act on the pericyte, which would act on platelet-derived growth factor. And the drug that does that is sunitinib, or Sutent. So let us look at this trial. This is a phase 3 randomized double-blind trial published in the New England Journal of Medicine. It's worldwide study that was done. I'll quickly run through that with you. The people who were eligible for the study had well-differentiated malignant pancreatic islet cell tumors and disease progression in the previous 12 months, sorry. It was balanced between Europe, Asia, Pacific, and the Americas, and arm A was to get 37.5 milligrams per day orally, continuous daily dosing of Sutent versus the placebo arm. It sounds difficult to do anything like that today. The primary outcome was progression-free survival. At this point in time, people didn't know how to measure this. Now we measure progression-free survival, overall survival, and then response rates. The types of tumors, including non-functioning tumors, nearly half the patients, and then gastrinomas, glucagonomas, insulinomas, vipomas, and a number of others, and a distribution of the Chi-67 index, which is about equal. So now we look at the Kaplan-Meier analysis of progression-free survival. And you heard this in 2 short slides. from Lowell Anthony is that it changes from 5.5 months to 11.1 months. You have a doubling of the progression-free survival on this drug with one of these neuroendocrine tumors. It's a very nice place to be. The hazard ratio is 0.397, which is the way they like to express the improvement in progression-free survival. Some people can say that represents a 61% improvement, and that's what it is. The overall survival at the end of the study, because it was cut short, this study was cut short because this is what was happening, that the people on drug were surviving and the people on placebo were not surviving. So the monitoring committee said, you've got to stop the study and you've got to put everybody on the drug. You cannot afford to carry on with placebo. And that, in a way, was a little bit tricky, and that's what actually made the FDA hang in there before they would approve the drug. So now, if you look at the RESIST criteria, look at complete response, partial response, stable disease, and objective progression, I just summarize this to tell you that everything is in favor of the drug compared with placebo. And now we want to say is, did we see any complete responses? And the answer to that is absolutely. Here's an example of a complete response. All these tumors over here disappeared. Do you see that? In about 7 months. And if you look further down here, all these metastases disappeared. And so that was a very salutary thing to see. Another example here is to see this over here, also doing what I told you about that patient of mine from Chicago, that we see cystic degeneration of the tumors. They just empty out, and you see these black holes as the tumors disappear and become necrotic. It's a very nice place to be when you actually see that. So we asked another question. What about their quality of life? Now, some of you know, or you don't know, that Vinik, my partner in life, and I developed the quality of life tool for evaluating quality of life in patients with neuroendocrine tumors. So is quality of life different with people with GI cancers? Younger age, functioning NETs, carcinoid, ZE, insulinoma, glucagonoma, lipoma, somatostatinoma produce awful symptom complexes that enter into your quality of life. If you have diarrhea and flushing all the time, right? Rare diseases prompt uncertainty of quality of care. And studies showed that quality of life over here in patients with neuroendocrine tumors is much worse than the general population. Okay. So now, if you look at this another way, if we look at global health, okay, a quality of life, can you just simply measure quality of life by the standard measurements, which are generic, measuring your physical activity, your cognitive function, your emotional function, depression, anxiety, social interactions, and activities of daily living? When you are faced with the tumor humors that are producing appetite loss, pain, ulcer, rash, hypoglycemia, hand-foot syndrome, diarrhea, constipation, fatigue, dyspnea, insomnia, financial stress, and nausea and vomiting. Can you actually do that? So the question was then, could we improve physical functioning, social functioning, emotional functioning, and improve your global health? And despite all the negative effects that you had from the tumors themselves. So the single biggest thing that emerged from our study is that you link very closely your quality of life to time to progression of the tumor. And this is what we actually showed. I'll show you very quickly. All these nice little things that happened, okay, is that if we measure functional scales like cognitive, emotional, physical, role functioning, and social functioning, we see that if we just do a global measurement, we can't show a change. The moment we break it down to look into what are the side effects of the drugs we're using, like diarrhea, and control for those, this is what we find. Quality of life, global quality of life improves, but the most important thing is your emotional functioning and your physical functioning improves if your tumor has responded. So we measured the bulk of the tumor if this responds. The second thing we showed is if we measured serotonin, serotonin levels are inversely related to quality of life. The higher your serotonin, the more depressed you are. And I can explain that to you if you want to know, because there's a nice synthetic pathway that's involved. So the composite scores we can show you. And lastly, emotional function. That's a breakdown of all those things. I want to show two quick cases to tell you where we are with this. This is a 13-year-old boy who was referred to us from the National Institute of Health with an initial presentation of severe dehydration, diarrhea, fainting, whole body pain, and flushing. He had a malignant tumor in the tail of the pancreas, which was metastatic extensively to liver. He was diagnosed as a pancreatic NET, a vipoma, and they told him he probably only had a few months to live. He was 11 and a half years of age at the time, and we did a distal pancreatectomy on him, and then we said, what can we do with him? So after his distal pancreatectomy, we put him on sunitinib. So now you were asked about, was this approved at the time? No, it wasn't approved at the time. I happen to be one of the centers. So we started him on a dosage regimen of 4 weeks on, one week off. We got his plasma VIP, the vipoma levels, to fall, but we also noticed that his pancreastatin, you've heard of that as the marker, was rising fairly dramatically, and we didn't like that. We switched him to Sutent continuously now on a daily basis, and then we got control of his VIP and his diarrhea. We added to that somatostatin. It didn't work, so we went to LAR. And now the tumor started escaping over time. He developed a few metastases. Then we started him on Timidor and Xeloda. We combined that with somatostatin. That's 4 years ago. He actually went to the Make-A-Wish Foundation and said the one thing he wanted in his life was to go and watch soccer in South Africa. And he took his whole family with him to go and watch the soccer in South Africa. I just saw him this week. He's alive and well, growing. He himself is playing soccer again. And we don't find any evidence of his metastases now, so he looks beautiful. So we're very happy with that. So let's just finish off then and say, well, what about the other side of the coin? The mTOR inhibition that I spoke to you about, and Lowell Anthony just mentioned to you as well. The reason that we know that tyrosine kinase inhibitors will work, because we know that patients with multiple endocrine neoplasia type 2 have a gene abnormality in the RET proto-oncogene. And that's the same pathway. It's the tyrosine kinase pathway. But what about the mTOR pathway further down for growth and survival? There are clinical examples like the tuberous sclerosis complex that have got abnormalities in mTOR expression, and you heard about its constitutive expression today. Let me just take you down there, and we'll take one or two examples, and we're done. But you need a little bit of history. You need a little bit of history. mTOR inhibitors, the drug was discovered in the soil of a South Pacific island. Rapamycin was discovered on Easter Island in the 70s. People who took rapamycin lived to be very old. So they started thinking this was the elixir of life. But of course, there were some UK experts who said, don't jump to conclusions in a hurry. We don't actually know all the things this drug can do. But scientists got hold of this and said, well, look what it does. There's the endothelial cell platelet-derived growth factor. Maybe if we combine this drug with somatostatin, we'll get a very salutary response. So I'll show you one case, because you've seen the data on the Affinitor study published in the New England Journal of Medicine. This is an 86-year-old Caucasian male who at 82 years of age presented with a malignant pancreatic islet cell tumor. And he had a partial pancreatectomy and splenectomy, had extensive liver metastases, he had intractable hypoglycemia. His blood sugar would drop to 20 milligrams per deciliter, and we couldn't keep him under control without giving him glucose infusions. He would just lapse into coma. When he came out of his coma, I asked him, what would he like in life? And he said what he would like is to go back to playing golf. He was 82. He'd like to play golf again. If I could get him back on the golf course, he would be a happy camper. So now we had to find out to target insulin secretion. It's very complicated. And some of you have actually today asked me about what goes wrong in pancreatic neuroendocrine tumors. Glucose-stimulated insulin secretion. And there are a number of ways that you get insulin release. But we used to use diazoxide to inhibit insulin secretion by binding to the sulfonylurea receptor. We also use calcium channel antagonists to inhibit that. We use somatostatin to try and inhibit insulin secretion as well. And we also used other drugs like hydantoins, which would inhibit insulin secretion. Why am I showing you this? Because we used all those things to try and get him under control. And in fact, the true story is what actually happened to him is the following. He was in hospital. He had astronomically elevated insulin levels, severe hypoglycemia, and you'll see what we did. We used diazoxide, we used hydrochlorothiazide, we used somatostatin, we used phenytoin, we used everything, and we couldn't control it. And then we said, what about the elixir of life? And what was the elixir of life? Rapamycin. You heard from Phil Boudreau about that. So we put him on rapamycin to say, let's see what we can do. And that rapamycin turns out to be a powerful mTOR inhibitor inhibiting all these pathways, but rapamycin does something that's very friendly for us. It suppresses insulin secretion and makes you resistant to the action of insulin. That's why its major side effect is hyperglycemia and diabetes. So we used that to see if we could actually get control of this person's terrible symptom complex. And lo and behold, it is 4 years later, he is now playing golf. He's a very happy camper. He's taking one small pill, not a $50 a day pill, 2 milligrams on a daily basis, which is keeping him very happy, and he lives at an institution with his family just over the road from us. This is what happened to his insulin. It fell from 60 down to 30. Glucose levels rose from 38 to 84, and insulin resistance levels went up markedly. And so we learned all these things about this drug in this person in this study. His tumors also virtually disappeared, and that's very nice. You saw this study from Lowell Anthony. That's the Afinitor study, and I don't have to go over that with you too. There are a couple of things about using Afinitor that you have to be aware of. You have to be aware of this. Sutent, the biggest thing that I encounter, one is hypertension, and two is the hand-foot syndrome. They come and show you their hands or their feet, or they get the desquamating rash. They can live with it, but sometimes it tingles. That's the biggest thing they complain of. Afinitor, when you treat drugs, it's an immunosuppressive drug, and you can get very severe upper respiratory infections apart from the stomatitis, and you can become severely hypogonad. Testosterone levels in males can drop to undetectable levels. And so that becomes something we have to consider. So there are limited therapeutic options. Activation of mTOR pathway supports NET growth and promotes angiogenesis. So everolimus in general is a very well-tolerated drug, and it's a very nice addition to our therapeutic armamentarium. Notice one thing about the study. People were taking everolimus as well as somatostatin. So we know that you need to take those two together. We know that. And in future, what we've shown too, and others have shown, is the combination of either an mTOR inhibitor or a tyrosine kinase inhibitor together with Timidar and Xeloda has become an incredible combination to use in PNETs, and we're happy to tell you that. Are we going to have genetic markers? I heard Phil Boudreau say we're going to mark all these people in the future, and we can identify who will. These are two new names for you that have come. These are histone modifiers that come after you have your genes, which code for the proteins that allow you to arrange the chromatin so that things are in the right place in the gene for other things to act on them. And one is called ATRX, and the other is DAX. This gene modification has just been shown in science from Hopkins to actually predict the overexpression of mTOR, and so that you will be able to choose people in future who can likely to respond to that drug. So we're going to have very nice markers for the future of predicting responsiveness to the drug. In 68 PNETs, mutations of the MEN1 gene occurred 44% of the time, DAX 25%, ATRX 17.5%. The mTOR pathway was involved in more than 14%. Mutations survived, no mutations greater than 60% died in 5 years. That's what you want. A huge difference in predictive capacity. So let me finish now and tell you that pancreatic islet tumors are a group of neuroendocrine tumors, including non-functioning carcinomas, insulinoma, gastronoma, glucagonoma, lipoma, and some less common types. I've told you about the incidence of these. About 50% of all NETs are PNETs. Where surgery is impossible, treatment options remain limited, and I've told you about liver-directed therapy, cytotoxic chemo, somatostatin analogs, and the fact that we've now got agents that can affect tumor growth and proliferation, the mTOR pathway and the tyrosine pathways, and we'll be able to predict in the future. When I started my career in GI endocrine tumors back in 1900, we only had... I dragged all these slides out of Noah's Ark anyway. They came 2 by 2. Surgery, then we went through the chemotherapy, embolization, and here I showed you the era of octreotide, how that's changed the natural history very dramatically. Now we have growth factors and angiogenesis inhibitors, and there are other novel therapies and combinations. So we're in a very nice place where we are, and once we recognize the syndromes. For those of you, we have the book that's up there with InterScience, but any one of you who likes free material, endotext.org has got everything I have to say, and it's free. You can download it. You can even download all the slides and so forth. It's provided by the Endocrine Society. Les de Groot is the chief editor, and I'm actually the editor of all the neuroendocrine tumor work. Thank you.